Let us take the techniques of vertebroplasty and kyphoplasty in greater detail. Theramon was a radiologist who injected bone cement in the aneurysmal bone cyst at C2 level and was credited with the first vertebroplasty ever. The concept was to inject the PMMA in a liquid state, which interdigitates with the bone trabeculae and hardens with time and within a short time. And it allows weight bearing immediately. The procedure could be done totally percutaneously. The equipment for vertebroplasty that you would require would be a Jamshidi needle, a radio-opaque dye, some low viscosity bone cement, especially one that has barium sulfate, 1 cc syringes, and obviously a fluoroscopy machine. The first step is to align the vertebral body so that the end plates appear parallel, and then that is how you should be eliminating the parallax. The vertebra, if you find that the pedicles are slightly rotated, then for a few degrees you may rotate the C-arm, but if it is greater than 10 degrees, I prefer to rotate the table rather than the C-arm. The pedicle is then marked and the skin is infiltrated with lignocaine about 1 centimeter superior and lateral to the proposed pedicle. So the Jamshidi needle, the purpose is to reach this point, the 10 o'clock or the 2 o'clock position in the pedicle, which is marked with the X. And the Jamshidi needle should start about 1 centimeter superior and lateral to this point of the skin. Once you enter the skin, it should land and touch the transverse process and to gradually allow the needle to walk on the transverse process till it reaches the junction of the TP and the pedicle. And then once you have the point, secure it by gently hammering it in. And then once you have secured the entry point, take a lateral shoot and see where your needle is, and you may angulate and readjust the needle so that the trajectory is correct. And then this is where you're going to start. So in the AP, when your needle is at the 10 o'clock position, it should be just here at the junction of the pedicle and the lamina in the lateral. Then as you go further in the AP and reach the center of the pedicle, it should reach the center of the pedicle on the lateral. And as you further progress and reach the medial border of the pedicle, it should reach the base of the vertebral body at that point. So these are the 3 important points at which you must take a lateral shoot, especially in the initial phase. Make sure that you frequently check the AP and advance in the lateral when you're doing it for the first few cases, and then you can continue to do them only in the AP thereafter. Make sure that the needles do not cross the midline in the AP, and after inserting the needle appropriately, it should reach the anterior third of the vertebral body. You may also perform a spinal biopsy at the same time, but mind you that please do not attempt it in a case of an angioma. Then if you want to perform a vertebrogram, it is possible. Otherwise, you may start injecting the bone cement, fill the 1 cc syringes with the bone cement, and then you can do a gradual controlled injection of the cement under constant flow. If you're using 2 ports, you may use both the needles in an alternate manner. If after filling the anterior third, then what you should be doing, you should withdraw the needle up to the middle third and then fill the middle third of the vertebrae as well. An optimum amount of 3 to 4 cc is required to be injected per vertebrae. Excess filling leads to greater vertebral stiffness and can cause adjacent level fractures. Also, remember, do not try to fill the posterior third, otherwise you can land up in complications. Avoid formation of cement tails by rotating the needle once the needle is allowed to once the cement is allowed to settle down. And after about 4 hours of the procedure, patient may be allowed to stand. The concept of kyphoplasty is not much different. It is quite similar, and what you can do is you can place a needle through the Jamshidi on a guide wire, and then on it comes a working candle through which you can put in a balloon, and once the balloon is inside, it is expanded to create a sort of a void in the vertebral body. And in this void, you can put in the bone cement, which will go in a much thicker consistency, almost like a toothpaste. And it will be also a much controlled delivery of the cement. Let me show you a quick video of the same procedure. So this was the patient who had a compression fracture of D12, and you can see I am inserting the Jamshidi needle. There I have placed it at its entry point in the lateral and the image. I'm inserting it gradually one after the other. And then as I advance it in the lateral, I also need to check it frequently in the AP as well. Once the needle has inserted in the right position, you may insert a guide wire over it, and over the guide wire the needle comes out, and over the guide wire then comes a small dilator. Over the dilator then you get a working cannula. You just see that I'm just putting a working cannula on top of it. And then this was the time when we used to do a double port kyphoplasty. Nowadays we only do a single port because it cuts down the expense to half. There both the ports are in position now, and that's the inflation of the bone cement of the balloon being done. The balloon is filled with radio opaque dye, and you can see as the camera shifts, yes, that's the balloon coming up. You can see the balloon getting filled up in the lateral image with radio opaque dye. And then in this case, here we are doing the double balloon technique. So you can see both the balloons filling up with the radio opaque dye. Once they have been allowed to live there for a while, they'll compact the surrounding cancellous bone, and then the balloons are removed, and then the cement is gently delivered using these special cannulas where the cement is slowly allowed to gradually get into is filled in the vertebral body. So this was that same patient, D12 compression fracture, kyphoplasty done for his condition, and he became ambulatory very shortly thereafter and went on to do quite well. So this was among the first 4 cases of kyphoplasty which I performed in November 2003. Another case of vertebroplasty, this is inferior end plate of vertebroplasty, D11, that was done. This was a case of D12 superior end plate fracture. This patient is almost 4 years is here, but I know her that she's already 8 years out and she's quite functional at present. This was a case of plasmacytoma which was done by my professor, Dr. Isidore Lieberman, my mentor who taught me the procedures, and this was what he used to call them as his signature. Thank you.